everybody. Thank you so much for joining to what is going to be our March webinar of the year instead of the February webinar, since we had to postpone this presentation from last week due to the snowstorm to this week. We are very fortunate to have with us Dr. Astrid Suchy-Dicey. And Astrid is a very long-term colleague and collaborator. She's currently an associate professor at Boston University School of Medicine. And Astrid has a long history of working with the Strong Heart study. I believe she started working with Strong Heart while she was at the University of Washington School of Public Health. This is where Astrid did her MS in epidemiology and also her PhD in epidemiology. And after that, while she's been in different locations and institutions, working with Strong Heart has always been at the core, at least of the things that I've known. And Astrid, together with her mentor, they led very important work in the area of aging in the Strong Heart study, as well as dementia, vascular dementia, and cognitive function. This is an area that is critically important as the communities are aging, and this work is very relevant also for us who are very interested in environmental risk factors for aging and for good, healthy aging. So with this, Astrid, thank you so much for joining us today, and the screen is yours. Thank you.
Thank you. I'm really pleased to be here with you all and to share this work. And I hope that it overlaps at least a little bit with the work that you all normally do in environmental health. I will share my screen, I think. Yes. Okay, so I'm hoping that you can see the PowerPoint presentation. Is that the case?
Okay.
Yeah. Well, feel free to speak up if something goes wrong technically, but I will just get started. This talk is titled Vascular and Alzheimer's Disease and Related Dementias in American Indians, Data from the Strong Heart Study. And as Anna mentioned, this is work that has been ongoing for over 15 years now, and with my colleague Deidre Buchwald, who's at University of Washington, and spanning since I was a student myself. I wanted to share first a brief positionality statement. For myself, I am non-Indigenous. I'm first generation American, European American. I was raised in the US Southwest, but moved around a bit in the Southern Plains and the Deep South when I was a teenager with my parents, and then eventually moved to the Northeast for school, and then the Pacific Northwest for graduate school. My research focuses on risk and resilience in brain aging. I mostly focus on Indigenous populations, but I more recently have started to work on African American groups as well. And I'm committed to centering community voices throughout the research process. I wanted to give a brief background to this talk and some of the content areas, just to ensure that we're all oriented. I know a lot of this will be probably pretty basic information, but just to get us all on the same page. I focus on cognitive aging and dementia and the neuropathologies like cerebrovascular disease and Alzheimer's disease that underlie those symptomatic changes. Alzheimer's is often used as an interchangeable term with dementia, but they are not equivalent terms. Alzheimer's is a specific brain disease with a specific set of neuropathologies and results in cognitive changes such as dementia in the long run, but it predates the onset of cognitive impairment and dementia as much as 20 years. And more recently, Alzheimer's disease and related dementias or similar kind of group terminologies have also started to encompass other neuropathologies like vascular, Lewy body disease, frontotemporal disease, And the reason is that there's more evidence, increasing evidence to suggest that these overlap or are mischaracterized in many people. And so there's many causes of dementia, not just Alzheimer's disease. We have significant disparities in knowledge of dementia and cognitive aging and the related neuropathologies in different populations. There is a commitment, a stated commitment from the Alzheimer's Association and the NIH and other groups to ensure that dementia care and dementia research is equal for all, but this desired outcome is still far from reality. And that's in part due to underrepresentation in national research programs by multiple orders of magnitude. In addition, many American Indians and Alaska Natives reportedly don't even believe that they will live long enough to develop these long-term conditions. And that's in part due to lifespan and life expectancy disparities. And so these are complex problems that permeate throughout the health networks and health industry. We have identified disparities in prevalence of self-reported cognitive decline using nationalized data from the Burfus study. They reported that American Indians and Alaska Natives were 1.8 times more likely than non-Hispanic whites to self-report cognitive decline. And so this is an indication that not only do we have little information about this group, but they do appear to have a higher burden of these conditions. Health disparities is a complex topic, as many of you are likely aware, or most of you are likely aware. This is a research framework published by the National Institute on Minority Health and Health Disparities. And you don't have to understand all of the different pieces, and I won't go over them all right here, but this is just to demonstrate that there's multiple levels and categories of influence from social, structural, and other non-clinical sources and influences on health that can permeate across different domains of influence from biological through the healthcare system. And they can impact individual as well as community and societal health. And so these are complex topics to study. We also know that there are disparities in health care, so not just in knowledge as well as in health occurrence or physical health, but there's also disparities in access to quality health care. And these can also relate to those disparities in knowledge and understanding of disease, such as through delayed diagnoses or misdiagnoses, low degree of specialist referrals, or even access to specialists at all, with many states and regions not having any specialist clinics for neurological support. As you all know, there are significant environmental disparities that impact Indigenous and Native populations throughout the United States. As an example, we've done some work in the Strong Heart study on arsenic, and I'll talk about this a little bit more later. But arsenic, there's disparities in exposure to arsenic through groundwater and well water that impact rural regions, and particularly regions such as Native reservation lands in a manner that's inconsistent and unbalanced across our US population. This also applies to many other toxicant metals, as well as other environmental exposures like air pollutants, access to resources such as housing and nutrition and water. And then, of course, there's acute hypertoxic events such as wildfires that also unduly affect rural populations. In the Strong Heart study, Anna mentioned that we have been doing studies on brain health for a number of years, and we started these in order to address some of these disparities. First, to collect high quality data to be able to estimate population prevalence and incidence of things like Alzheimer's and vascular dementias, as well as traumatic head injury, using a variety of different data types, and then to use those data types to construct models that help us to better understand risk, etiology, and progression of disease. And then to compare those models and that collected data to knowledge that we already have about the majority population and existing disease models. Some of the considerations in doing community-facing research, which I'm sure you're very familiar with, given the Superfund project, are based in the Strong Heart Study and community-based participatory research principles. So that includes things like shared ownership throughout the research process, development and respect for relationships and the knowledge and strengths of the communities, respecting tribal and data sovereignty, conducting detailed ethical review at multiple levels, and then also accounting for things like participant lived experiences that can result in hesitation, higher burden of participation in the research process, compensation issues, and then making sure that there's adequate clinical supports and materials for individuals who may not have access to those in their regular life. So one of the things in our study that we really had to pay a lot of attention to was cultural awareness in the data collection process, especially with respect to cognitive assessments and accounting for things like deep social or cultural structures and worldview, which can impact content and criterion validity in cognitive testing. Sorry, my nose is tickling because I have allergies. In measuring cognition and ultimately cognitive impairment or dementia, we are interested in measuring or understanding actual cognitive status. And to do that, we're inferring that it's similar to the cognitive test performance that we're actually able to measure. And however, there are multiple confounding and biasing factors that can influence our ability to measure cognitive performance on tests and then to infer actual cognitive status from those test scores. And things like social disadvantage or adverse childhood experiences, educational quality or quantity, being bilingual can be both an advantage and a disadvantage in testing, especially in test validity. Having access to healthcare and presenting at a consistent level or time point in the disease course, and then things like multiple testing with practice effect can all influence test validity, accuracy, and interpretability. And so we have done a lot of work to try to understand these factors, but also to account for them in the research process. And so ultimately, we started an ancillary study with the Strong Heart Study in order to answer some of these specific aims. And that's shown there in, I don't know if you can see my mouse, probably not. In the yellow boxes.
We can see it. We can see it, Astrid.
Okay.
Yeah, very good.
Yes, right here in the yellow boxes is our so-called CDCI study. It's also internally known as the Strong Heart Stroke Study. And this was an ancillary study within the original Strong Heart cohort, which was started in 1989 and included adult participants from 13 different tribes and communities. Later, one community withdrew, so I'm counting 12 communities here. And then this is about 25 years after the beginning, or 20 years after the beginning, and then now almost 35 years. There's been other phases of the parent study. There's been an ancillary family study, and then both of these have been followed through time to what is ultimately now phase 7, which we just completed data collection for and shown here in this green box. And we have cognitive data for the first time from this group. And so that's a younger group that was followed through time, and they're now ages 30 through 100. So we have a little bit younger data, but those data are brand new. And so I won't focus on them in this talk, but I will mention them a little bit at the end. So a little bit more about these individual cohorts. This CDCI ancillary study, we did 1.5 Tesla MRI on the brain, and then we processed those using a variety of different processing techniques in order to estimate brain volumes, in order to evaluate for infarcts and white matter hyperintensities and other metrics that are related to vascular and neurodegenerative loss. We conducted detailed cognitive testing using multiple test batteries, including some that are used by the National Alzheimer's Coordinating Center's programs for the Alzheimer's assessments across the country. We did detailed clinical exam, health behaviors, medical history. We collected some ATN or COR2 blood biomarkers and have a wealth of self-reported questionnaire data as well. In the phase 7 cohort, we also have a number of ancillary studies focused on things like cognitive and psychological resilience, psychological stress and substance use. And then we did additional cognitive testing using the NIH Toolbox battery and other tests, as well as a clinical exam, and in concert with other phase 7 ancillary studies that are focused on other topic areas and may be harmonizable or available in combination in the longer term. So here, as I mentioned, I'll focus primarily on the stroke study or the CD-CHI study. I might interchangeably use those terms, so let me know if it's confusing. But we did 2 exams so far, the first in 2010 to 13 and the second in 2017 to 19. So there was an average of 6.7 years between those follow-up visits, and the ranges between 4 and 9 years. So it's a good amount of time to observe cognitive change in both the healthy as well as impaired group. And it's reasonable to expect in this group that's age 65 and older that we would see conversion over time from cognitive unimpaired to impaired. However, the majority of this population is already hypertensive. Many have diabetes, a little over half, and a strong proportion have chronic kidney disease, increasing between the exams, probably representing the age and the transition of development of renal or diabetic nephropathy in this population. Some of the initial findings from our MRI exams, we found that about a third of the population has evidence of vascular brain injury, whether large infarcts or lacunar infarcts, which are subcortical and representative of vascular lesions, or with white matter hyperintensities, which are small vessel disease throughout the brain space in the white matter. We also found that about 2/3 of the study population had abnormal sulcal or ventricle enlargement and some evidence of loss in volumetric values above what would be expected. And this is in comparison to findings of about findings in non-Hispanic whites from the cardiovascular health study, which is a similarly structured cohort. This population had about 40% more vascular disease than that population. And so this is a significantly higher prevalence of abnormal MRIs compared to what would be expected. As I mentioned, we did some volumetric analysis using different software tools. This is a SPM CAT toolbox, and we estimated that about the total volume loss between the 2 examinations that were on average 7 years apart was about 0.5% per year, with the maximum loss of 1.5%, assuming a linear loss. There was significant loss in relation to diabetes across all regions. We were interested in diabetes because it is a significant vascular risk factor. It's also really related to Alzheimer's disease. And so we were interested in what brain regions might be related to this condition. And we found that especially loss in the frontal lobe and cerebellum were especially strong, which is counter to what we might have expected to see, which would be initial loss in the hippocampus and perihippocampal gyrus and entorhinal cortex, which are targeted by Alzheimer's disease. And so this suggests that there's a complex disease framework happening here that's not just related to Alzheimer's disease and diabetes together. However, we did see losses in all regions, including the medial cortex. And so diabetes does seem to have a broad effect. So moving into the cognitive test data, we initially found that the cognitive tests at the first exam were left or downshifted from what would be expected in terms of the mean and typical scores for a general group that includes both impaired and unimpaired individuals. The means in our study population were below what would even be considered diagnostic thresholds for cognitive impairment or dementia in the general population. And so we thought that those scores were quite a bit lower than we would have anticipated. We have conducted, and I'll describe this a little bit more, detailed test validity assessments and have found that these scores do have interpretability in this population. And so these are fairly reliable scores. And so the question is, what is underlying these downshifts or population shifts in test performance? But in general, they were quite a bit lower. This is just data from the second visit, but it's similar to the data from the first visit. I mentioned the psychometric analyses to validate the tests and ensure that the test scores are interpretable in the way that we think that they should be. We've so far done detailed analysis for 5 of our cognitive tests, and we've found that the scores are generally interpretable in the same way that they are in white and other populations, suggesting that they would be comparable or harmonizable with other groups. We did note important differences by education, age, and sex in different tests, as well as noting that depression and bilingualism have some influences on some of the tests, suggesting that those also should be taken into account when comparing differences across groups or when considering an assessment in a single individual for the purpose of diagnostic or clinical assessment. This work is ongoing for a large number of tests, and so more information will be forthcoming about those different tests and test domains. We've done analyses to assess the normal or expected scores. These are often called standardized scores for this population. And we did this in both the whole cohort as well as in individuals that we assessed as having intact or normal cognition. So a kind of robust, normalized assessment to see what would be expected for an individual across a different range of strata, socio-demographic strata, such as age, and to see what would be expected so that then an individual who's being assessed can compare their score to those expected scores. And these scores overall decline linearly with fluid performance and age, and this is what would be expected. And the different score ranges do appear to be lower, however, than would be anticipated for the general population. And so that may be taken into account or reflecting a number of social determinants that are kind of latent factors influencing cognitive test performance. And so these scores are a first effort to trying to redefine what would be expected performance in this population. One of the caveats here is that this group is now aged 70 and older, and so we may need earlier ages and data from younger groups in order to look at truly pre-symptomatic or undiseased individuals, as well as a larger range of age groups. I mentioned earlier that we had found associations of cognition with education. We assessed length of education because that was the information that is usually used to contextualize cognitive test performance. It's also the data we had initially in the first exam. And we found that there was generally a lower correlation of years of education with a measure that represents quality of education or achieved educational capacity. So this is a measure that accounts for differences in educational experiences, or like I said, quality of education. And in general, the correlation between those two measures is much lower than it is in the general population, suggesting that using year of education as the proxy for this achievement value is probably not as well justified as it is in the general population, and that direct measurement of this quality of education metric is likely to be needed, but also that more research is needed to understand the influences of education on cognitive aging. Years of education is also often used as a proxy for cognitive reserve or resilience. This is because education quality and more education can contribute to neurodevelopment and better neuroplasticity, which is thought to contribute to a better trajectory in cognitive aging and slower development or progression of dementia among people who have an underlying neuropathology. But we found that although years of education was strongly related with cognitive resilience, it doesn't fully capture the breadth of the lived experience and interpersonal learning differences in this population. And so that suggests that there's a lot of other latent factors that are not being captured in these different metrics. We looked at depression and its associations with cognition. We found, first of all, that 20% of this population has what would be considered clinically significant level of depression symptoms. This is not a diagnostic test, but it is used for depression screening. And a CESD value of 16 or higher is generally considered an alert value or consistent with clinically significant depression. And 20% is higher than it is in other populations of a similar age. We also noted that CESD score, which is continuous depression symptom score, was continuously associated with lower cognitive test scores across multiple domains, also with higher risk of stroke and findings from MRI of vascular brain injury or atrophy. And so it seems to be an important value, although it's not yet clear whether depression can result in these changes or whether these changes result in depression or perhaps an iterative or circular kind of temporality. So I mentioned earlier that we did some cognitive assessments among people who were assessed as unimpaired. We did that based on what's considered a pretty robust method of assessing cognitive impairment and dementia in a observational study. We used a consensus panel of providers, neurologists, and neuropsychologists, as well as neuroepidemiologists familiar with community-based data and with cognitive aging. We did a detailed case review of accumulated cognitive performance over two time points so that we could observe both inter-individual differences and low or poor performance, as well as intra-individual changes over time, such as rapid decline. Once we defined status for an assessed set of cognitive tests as mildly impaired dementia or impaired other, such as it's a kind of technical category terminology called impaired not MCI. I'll abbreviate it INMCI, but this is a kind of other type of or other pattern of cognitive impairment. Once we assessed those using cognitive data only, we then also looked at clinical factors for those who had some degree of impairment and assessed probable underlying etiology, including Alzheimer's, vascular injury, or traumatic brain injury, and an other category that would encompass other conditions such as Lewy body dementia or frontotemporal disease. The prevalence of cognitive impairment in this population or in this cohort population was also quite a bit higher than it is in the general population. We had 35% of those aged 70 and higher as assessed as having mild cognitive impairment, which in clinical terms is often called minor neurocognitive disorder on the DSM-5. We also had 10% with dementia or major neurocognitive disorder, which is collectively with the INMCI category of 8% over 50%. So that suggests that more than 50% of this population has some degree of symptomatic cognitive impairment that's detectable using cognitive testing. In the context of validated cognitive test instruments, this does support the prior findings that our mean scores were below cognitive thresholds or diagnostic thresholds used for other groups. And so that is consistent, suggesting that we don't have measurement error so much as we have a heavily burdened population. However, we did look at diagnostic performance for these individual cognitive tests for cognitive impairment, trying to test whether those diagnostic thresholds perform well in this group. And we found that discriminant performance for any one test was very poor, less than 60% for all of them, and most of them were around 50%, maybe slightly higher, suggesting that a coin flip would be as good as using a single cognitive test to discriminate mild cognitive impairment or dementia for a given individual. And so we did do a group test to see if a battery of tests collectively improved on this performance. And we did find that group performance was, I believe, in the 70% range. And so it was a little bit improved, but still with a lot of room to improve further. And so we're still trying to understand why these individual tests perform so much more poorly for this population than they do for the general population, given that we know that the test validity is generally good. And so more work is needed in this area. We assessed genetic risk from ApoE, a major risk factor for Alzheimer's disease in the general population. Many of you have probably heard of this. This is one of the key clinical factors underlying general population risk and population attributable fraction for Alzheimer's dementia. Something like 30 to 40% of population attributable risk is often attributed to the ApoE E4 allele, which is the high risk allele. In this cohort study, we found no association with ApoE E4 risk allele with either cognitive or MRI features. These null findings are notable because this is such a strong risk factor in other populations that to have absolutely no effect in this population is striking. Similar findings of null or very weak effects have been found in Hispanic, Latino, and African American groups, although the literature is varied. There are multiple possible explanations for this null finding in this group. It's possible that we have selective survival, where the most heavily affected are being selected out of the observable risk frame by not even making it into our ancillary study 20 years after the beginning of the cohort. And that would be consistent with a heavier and earlier burden of disease impacting this group. It's also possible that there's excess risk in the unexposed in the group that does not have the risk allele, but has a number of other conditions like diabetes and hypertension and vascular disease. There may be latent resiliencies that also are protecting people that have the risk allele that we don't yet understand. This is a very different population from the general population in terms of many of the social determinants and cultural determinants related to health. And so there may be resiliencies that are yet to be understood and would be considered latent resiliencies. There may be undefined gene environment effects or reporting bias favoring data from the majority population. And there are groups that are looking at genetic architecture influencing expression of the risk allele or influencing inheritability of different patterns of this genetic risk factor. And so I think that those data and those associations are not yet well understood. And then I'd like to mention the Lancet Commission. I mentioned earlier population attributable fraction. This group published almost 10 years ago, a number of modifiable risk factors that influence throughout the life course that combined can be attributed to a large proportion of population risk or population attributable risk for dementia. And these are factors that are selected as modifiable factors, and so they could be involved in primary or secondary prevention and improvement in public health programs. And so these are things like improving on hearing loss, high LDL or lowering lipids, depression, treating and preventing traumatic head injury, and so on and so forth. So we have done an analysis in this cohort to evaluate the prevalence of the risk factors, comparing the Lancet report, which represents the general population, with our population of American Indian peoples from community-based settings. And we found an interesting pattern where some factors are higher, like I mentioned, hypertension and diabetes. These are generally higher in this population than in the general population, as we would have expected. I mentioned depression and I didn't mention traumatic head injury, but both of those are quite a bit higher in this group. But some factors are actually prevalent at lower levels, such as the high LDL, which has been actually reported by the Strong Heart Study previously from a midlife assessment, or physical inactivity. The threshold of complete sedentary lifestyle behavior is prevalent in a lower proportion of this group. I didn't include here data reflecting alcohol use, but alcohol use at the risk level of 21 standard UK drinks per week is also prevalent at a much lower level in this population than in the general population. In this group, it was less than 1%. So I wasn't really even able to stably estimate it or use it in subsequent analyses. And then we haven't been able yet to look at hearing loss, vision loss, or air pollution, although I know that the air pollution data are forthcoming. And so I'm excited to see how those compare. We also have done some analyses looking at cognitive resilience and cognitive reserve. I mentioned some latent factors that could be important to these. Sorry, my dog is making noise. And we defined cognitive reserve using a intra-individual regression of cognitive performance over MRI findings. So it's essentially a metric of relative cognitive performance given the degree of neuropathology in an individual and whether it's higher or lower than the mean, and then estimating to what degree it's higher or lower than the mean, assuming that the linear mean would be the expected value. And so this gives us a kind of inter-individual relative metric of better or worse than expected cognitive test performance given the degree of disease that's underlying cognitive change. And we found that this metric was related to better education, as I mentioned earlier, also related to better income, higher quality of life, and related to lower prevalence of diabetes and depression. And so these are factors that might be related to cognitive reserve and would be things that would be targetable in prevention or cognitive resilience sustainment programs. Environmental toxicants. I know this is what's really of interest to all of you. We have found in this study that even low or moderate exposure from urine, as measured by urine biomarkers, are associated with both imaging and cognitive outcomes in this population. We also have found that these associations with shortened telomeres, poorer lung function, more diabetes, more cardiovascular disease, as you all have seen or produced in this study population. And then here we have some data. This is ongoing work by our colleagues at Columbia and elsewhere. And so I'm really happy that this is getting more and more effort and attention. So some of the works that are in progress in this area is the metal mixture models and statistical methods done by Linda and her groups, looking at health-related quality of life and mood in association with these metal mixtures, done by an early career faculty here at Boston University. Areal matrices and things related to area deprivation or other indices that are measured on the geographic scale, done by multiple different faculty at Oklahoma University and at Washington State University. looking at cognitive variability and patterns of longitudinal change in cognitive assessment by a faculty and her students at Washington State University, or now at Rutgers. Sorry, she moved. And then work on the ApoE and other biomarkers by individuals at Stanford and elsewhere, looking at cognitive reserve and resilience by, among others, colleagues at our Arizona Center, the Arizona Field Center supporting the Strong Heart Study, looking at psychometrics and measurement validity, colleagues at Washington State and elsewhere, and then the air pollution and particular exposures that I mentioned. So some of the strengths and limitations of this work as a whole, we have found that, in summary, we found that vascular injury and neurodegeneration are more common. Mild cognitive impairment and dementia are more common than in the general population. I didn't show this, or at least I didn't mention it if I did show it. We did find that both vascular and Alzheimer's diseases equally contribute to those cognitive outcomes, to MCI and dementia in the primary and secondary etiologies. But we also had a significant number of people who, about a third, who had both etiologies recognized. And so that suggests that they have a substantive contribution in this group. And in particular, vascular injury is noteworthy because it's a much lower contributor to the general population cognitive outcomes. And so that suggests that this group has either more or worse vascular burden contributing to cognitive impairment. The patterns of risk were different and not all uniformly worse than the general population, suggesting that this is a very a unique population with a complex pattern of risk and burden, suggesting that things like intersectional or complex interaction models are needed. And then despite psychometric validity from our detailed assessments, we likely do still have some measurement bias influencing the cognitive testing and resulting in lower diagnostic discriminant performance. I did mention that we may have selective survival, meaning that individuals that were most affected or earliest affected may have been selected out. And so we do need to examine and include younger groups in future research. We likely have earlier, faster, and possibly more complex pathogenesis, suggesting that we need to conduct intersectional or interaction evaluations and develop more complex disease models. However, this is a population-based recruitment. It is representative of the group that have aged to this age, and it is a heterogeneous representation of multiple regions, multiple tribes, with detailed, objective, standardized longitudinal protocols. And so these are rich data and available for collaboration. I know that I'm running kind of short, so I'm actually going to skip over other work into cultural and social determinants that we have ongoing. And that's all the work from the phase 7 study that I mentioned earlier. So I can share that if anyone's interested, but just due to time, I will stop here to acknowledge all of my many collaborators, all of the participants, communities, and field centers that have contributed to this work, all of the individuals, students, faculty, collaborators, and colleagues, as well as, of course, the funding that supports this work. And I don't think I have any questions slides, so I will just stop sharing and see if there's any questions.
Thank you, Astrid. This was, wow, very informative, very comprehensive, very well done, very, very complicated data, and done in a very careful way. So thank you, and very important public health problem, obviously. Good, questions and comments for Astrid. Who wants to start? I have a very quick first question. Maybe I can start. And this is with, if you exclude people with diabetes, because we know diabetes is so common. It's so common, it's such a high burden, metabolic disease is so important. And we know that metabolic disease is also a risk factor for dementia. Is it still, even among people without diabetes, you still see this high burden? Have you run that stratified analysis?
We haven't. That's a low-hanging fruit, and I'm embarrassed to say I hadn't thought of doing it yet. So I think that that's a definite next step that we should do, is to do a diabetes stratified analysis. I mentioned that we have blood biomarkers. I didn't show those data because I had to be really a heavy editing on what to share here,
Of
because
course, you
there's
have so much.
all the time in the world. But yeah, I think we could look at cognitive as well as MRI and blood biomarkers and possibly see, relatively speaking, those who are non-diabetic and those who are diabetic, and if there's like significant differences, not just testing between them, but seeing the pattern of development. Yeah, that's a great idea.
It might probably not be the only factor. It would be too easy, but it could be one element. So I think it's worth checking. So
That's a great
that's
idea.
really good. And then the other question I have, I think it's very intriguing, and in a way, I am not completely surprised that this cognitive testing doesn't seem to work well, in the sense that, I think myself of my grandmother, and I could imagine she would do horribly. She never went to school. She only went to school once in her year, but she was a pretty smart person. But just these tests were not going to work for her. Like, she lives in a different environment, world. It's a different way of thinking. And so I wonder if maybe the fact that when you look at this correlation with years of education, you don't really have the full spread. I mean, you have some people who are highly educated, but very few. And so when we are lacking the full distribution, maybe it's much harder to see the correlation. Well, when in other groups, you have a full distribution of years of education with people with very few and others with very high. So maybe it's much easier to see the correlations there. So lacking the full distribution might be one reason. Do you think that makes sense? Or
Yeah, I think that that's a really astute point, and I think that that's probably part of what's driving the lower correlation and lower kind of associative value between achieved education and years of education. In the lower ranges of education, you probably have a lot more residual variability, and so some people are going to do fine, some people are going to do very poorly, and it's a lot harder to tell them apart. And so you don't have that kind of really closely correlated group in the upper ranges to improve the overall correlation estimation. I think that the reason that that is true is likely that there are complex factors influencing cognitive testing. And so it may even be better that we don't have the higher education group, because it means we can focus on what are the factors that are creating this, like, highly heterogeneous, highly varied, association. And so are some subgroups do fine, and others, like, that are definable, such as like bilingual individuals, are they just at a disadvantage because they're thinking in two languages at once? They're trying to translate the instructions from possibly their non-dominant language into English. There's other, like, attentional requirements, thinking in multiple languages. There was a very recent report suggesting that essentially looking at patterns of connectivity and functionality among bilinguals is equivalent between the two languages, which is super fascinating, suggesting that there's a shared resource that people use when they speak two languages that isn't available to those that speak one, but maybe they have, a greater metabolic, rate in the brain that is exhausting them. Maybe they're more likely to be exhausted by a long battery of tests. Maybe there's particular tests that they do well in and do poor. And this is just for bilingual. I mean, there's depression, there's all kinds of other latent factors, like, did someone have enough to eat today, last week? Are they stressed about their grandkids and, whatever is going on? And so there's all of these different factors some of which we know about, some of which we can measure, and some of which we don't know much about and should maybe develop research to look at. And so I think, yeah, I think it's a very good point, and definitely we need more research in that area.
Good. Other questions, comments for Astrid?
Hi, Astrid. Thank you. Oh, sorry. I went
No,
on.
you can go.
Just a
You go
very
first,
quick
and then we'll.
question. First of all, great presentation, and I'm also very intrigued about the measurement problem, and I love to talk more about it. But I wanted to ask a question about the social determinants and whether you have also considered, intersecting the social determinants with the environmental exposures and just if you can give like a short, highlight of what excites you in this new area that you're exploring with the phase 7.
That's a great question. I think that that's definitely an area we need to work on. I know that some of the ongoing work by some of the colleagues that I mentioned are interested in some of those effects and looking at mixture among the metals for toxicant exposures. But there's, as you mentioned, also possibly interaction with resource-related social determinants, institutional and structural determinants that could contribute as well. And I don't know that there's a lot of work that has been done on that yet, certainly not in this group, but I think that that's a great area to explore, and we definitely should do that. Yeah. Maybe we could write that into the renewal.
Yes.
Wonderful. I see Stephanie has her hand raised. Stephanie, please.
Hello, Astrid. Thank you for your talk. I just have a clarifying question about the ApoE4 data. Was that looking at an association between the variant status and all the different types of dementia in aggregate, or did you also look by dementia type?
Yeah, we looked at all of the different cognitive tests continuously. We looked at our MRI features, both categorically and continuously. And then we also looked at dementia and mild cognitive impairment as categories in relation to the risk allele. So all of the above. I kind of collected all of the information and said, we found nothing. We have a very mild association with one of our biomarkers, the amyloid 4240 marker. That's a marker. Amyloid beta is related to lipid metabolism, as is ApoE. And so it's not too surprising that we might have an effect there. We did have a positive effect with blood lipids, and so with ApoE. And so that suggests a kind of positive control that we have at least a detectable association with a different metric that we would expect to see with the risk allele. However, one caveat that I didn't mention was that we were only able to look at people who do or do not have the risk allele at all. We were not able to look at people who carried 2 risk alleles, which is an even higher risk group, because there were so few of them. We essentially have none remaining in the observed group in the study, in the ancillary study. We also were not able to look at E2, which is a so-called protective allele, and so because we also had too few. And so there's kind of this really limited analysis we were able to do, and this is an area that absolutely deserves future research, probably in younger groups and larger cohort studies in this population, so that they can see those different effects on a kind of more complex basis.
Thank you very much.
And I was going to ask you, I noticed that the prevalence of the ApoE4 allele was pretty high, having at least one allele, because as you mentioned, the numbers would be too small for the two. But I saw you said 30% prevalence. So that's pretty high, no? Because I remember I've heard that in some populations this is very low.
Yeah, it is about what we have in the younger group. And so we didn't think that because we have a similar proportion in this older group, it's probably not only selective survival contributing to the null effect, because we do have a kind of consistent proportion. Of course, that's combined prevalence of people with a single allele and people with 2 alleles. but
Yeah.
it's about what we would have expected for a group that's not selected. So it's hard. It's really hard thing to explain, but I think these are open hypotheses that warrant investigation and future study.
The other thing I am thinking, because the study was mostly with the main cohort. That's how you started. And I feel that in the main cohort, there is indeed a lot of survival bias, in the sense that the people who were in the study, and especially the ones who continued, so that you could include them in your study later on, they were probably more resilient. For instance, there is something that is kind of fascinating to me, is that age actually doesn't predict diabetes in the main cohort, incident diabetes. And that doesn't make any sense, because we know that the incidence of diabetes goes up with age. And it's because there is some kind of real strange survival bias, that the people who were older at the same time were more resilient already, while the younger one were less. So it's very intriguing. I think they're very complex risk factors and connections there, and who was in the study versus who didn't manage to continue later on. I think there are things happening, and that probably influences a lot, and especially for some outcomes more than others. And I think dementia might be one, because despite the fact that you have high burden of dementia in the population, you're probably missing a lot of people who are not able to make it because it was much more severe. So that makes it complicated. Yeah. Okay.
Totally
Other questions or comments in the last minute? Oh, I think even it's time now.
Well, I apologize for not including a slide with my email, but others on this call know how to get a hold of me if you have a difficulty Googling me. So I'm very happy to talk about this at any time. We're very open to collaboration and would love for these data to be used. There's a lot of open questions and a lot of opportunity to work on important scientific and public health problems here.
Yeah. Congratulations. Thank you, Astrid, for this important work. Thank you for the talk. Thank you. Okay. Bye, everybody.